Thanks, Chris. It's been a great day to be here. I've met some fantastic people. There's clearly a lot of energy and passion here for informatics as well, which is fantastic. I do realize I'm standing between you and the weekend, so hopefully this will be worth your time. But I think all of us here share passion for this, and mobile technology and innovation specifically is something that I think I get up every morning excited to try to contribute to in some way. And obviously that's a team effort and something that one person can't do alone. And so behind everything you see here, there are lots of people working with me and around me and at Duke to help make this possible. Certainly not something that I've done alone. But start out a little bit more lighthearted here.
Emma. Huh? Emma. 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 Emma.
It never gets old. I'm passionate about mobile technology, but I think I'm also the first to recognize the limitations of that technology. Mobile technology is not ever going to be the panacea to solve all of our problems, and only when we understand what the limitations are can we put ourselves in a position where we can find solutions to those limitations. And I think clinical informatics is a space where that's exactly what we want to do. We want to try to find what those limitations are and find solutions for them so that we can help make a difference in the lives of our patients and providers. So to put this into a little bit of context, this information was taken from the CDC website showing the adults with chronic disease in the U.S. And you can see that half of every adult in the U.S. has at least one chronic disease, and 25% of all adults in the U.S. have 2 or more chronic diseases. So this is a huge problem, and one that traditional research in medicine has done a lot to help and to remedy, but certainly has not completely fixed the problem. And health IT, we think, can play a huge role in improving that. And so this is a slide that came from, it's an image that came from a journal of nephrology. And one of the PIs on this study, or on this research, was at Duke, and it talks about how we can combine health IT systems with community resources to lead to improved outcomes. And I know I'm preaching to the choir here, so I'm not going to dwell on this a lot. But one of the ways we can subdivide a lot of the informatics work that we're doing is in the work that is patient-centric or used by patients, and the work that is provider-centric or used by providers, physicians, PAs, NPs, PT, down the line. And it's been helpful for us to divide it in that way as well because of the various needs and the unique requirements with each type of application, whether it's security requirements, authentication, or the technology itself. And we have been thinking of this as well in terms of making these technologies available wherever you're at. And so if you have a great app by Duke or whoever else, we want to be able to take that with you in your pocket wherever you're at and make these technologies mobile because we want to meet our patients where they are, and our patients and providers are now increasingly mobile, and we finally have technologies that allow us to do that and to meet them where they are. So to start off by talking about some of the patient-centric technologies, and Chris has referenced some of this. Apple and Google has actually gotten into healthcare long before Apple did, and you've seen some of the work that they've done there. More recently, though, Apple's HealthKit has given us a new and unique way to approach patient-generated health data and collecting data so that we can get that into what we refer to as a single source of truth, the EHR, so that we can then do stuff with it. You need data so you can do stuff with it, and this is one way to get that data in a standardized way. I'm not going to talk a lot about Google simply because we're not working directly with Google in the same way right now, mostly because the technology provided by Google doesn't really meet our needs yet. I think there's been some concern. I think people are a little bit more wary of Google just because they know so much about you. And in healthcare, we're very careful about the data that we share and about the security. And Google is signing BAAs now, which I think is a big step forward. But also the technology that they're providing, which is analogous to HealthKit, it's called Google Fit. It doesn't quite work the same way. They haven't defined the data elements the same way HealthKit has. And it's geared more towards fitness rather than health, including vital signs and the things that we need, like blood pressure, glucose, weight. And so we hope Google will get there and that they will make it as easy to use, but it's not quite there yet. But again, we want to meet our patients where they are. I don't care if it's Apple or Google or BlackBerry, whatever it might be. Maybe I do care if it's BlackBerry. Not too many people are using that these days. But we just want something our patients will use. So to talk about HealthKit, are you all familiar with HealthKit? Does anyone not know what HealthKit is? You probably wouldn't admit it if you didn't in this group. That's okay. So HealthKit is a technology that makes it possible for patients to collect to measure themselves in some way, whether it's weight, glucose, blood pressure, activity, and to save it to a central database on their device. And the key, and what makes HealthKit work, is Apple has standardized about 100 different data elements, and they've basically told everyone this is how you use it, which is a good thing in this case because it means that everyone can work to the same standard, even though it's a proprietary one. And then the user has complete control over that data, and that's the key here. Apple can't even see this data, nor do they want to, and they've confirmed that to us multiple times. This data is not synced between your phones using iCloud in any way, and so it's on only one device. And then the user has full control over which apps have access to that data. At a per data element level, they can control what has access to what, which we think is a really good thing. So the user can choose to share it with whatever they want. But to talk about the different devices, here you have all these devices that feed this data in meaningful ways, and then that allows us to do cool stuff with it. One of the cool things that we want to do with it is to get it into the EHR, as I've mentioned already, and the way that's done is through the MyChart mobile app. And any EHR vendor could create an app that had HealthKit integration, and many have, and that requires the patient to enable that app, in this case the MyChart mobile app, to read that data from their HealthKit information. And again, the patient can turn it off at any point in time. But once the user, the patient, makes that connection, the beauty of this is that it then happens in the background seamlessly. Anytime the user adds another data element by stepping on a scale or by putting on the blood pressure cuff, that's automatically sent through the app and to the EHR. And when the provider puts an order in the system to enable this for the patient, they can set the thresholds for this information as well. So if the blood pressure, systolic or diastolic, crosses a certain threshold, the provider can be notified. And that's where you start to see the power of something like this. I think there are a number of issues that need to be worked out to make it truly scalable to lots of providers. And we talked about that at some of our meetings earlier today. But at least the seed has been planted to be able to do some cool things with this. And just to give you one example, one of our early HealthKit users, and he gave me permission to share this this information, was traveling to France, I believe, and you would think that if you're in France, you're going to be relaxing, and presumably he was, because he was starting to feel lightheaded, and he was taking his blood pressure like normal to try to see if it was low or high, and he saw that it was a little bit low, but he didn't know what to do about it, and I think he kind of left it at that. But he got a notification from his provider the next day saying, "I noticed your blood pressure is low. I just got notified. How are things going?" And he said, "Well, I've been a little lightheaded." And his provider said, "Well, you should probably cut your lisinopril in half," which he then did, and then enjoyed the rest of his time in France without any lightheadedness. So you can see a real example. There's one tiny anecdote of how this can be used in real time or near real time to help patients take better care of themselves. And here you can see what these values were You can see starting at the bottom are the older values. 120s over 60s, very good control of his blood pressure, and then a few values, 108, 111, 103 systolic, with diastolics in the 50s and 60s. And then after he cut his lisinopril in half, back to 120s. And so a really interesting anecdote. Another anecdote that we had was one of the first patients enrolled in our HealthKit pilot. And this was a CHF patient, congestive heart failure. And this is a graph of his weight. And you can see the y-axis there is the weight of the patient. Hopefully that shows up. It's a very thin line. But you can see that the weight is slowly increasing, and then you see a sharp drop down again. Any ideas what happened at that sharp drop? What's that? Lasix, I heard someone say? Yeah, so he was admitted to the hospital, actually. The exact thing that we want to try to prevent with technologies like this. And as you can see, he was admitted there and then discharged a few days later, and much better control of his weight after that admission. But the intent of this particular study was not to intervene. It was simply to see if the technology was valid, and we were kind of looking back retrospectively to see what happened. And so we found out about this. But you can see how if the study had been designed to intervene based on certain thresholds, we possibly could have intervened. You can see a clear trend of increasing weight, and giving that patient a call saying, "What's up?" Try to get a diuretic on board before they get into the hospital. So here's additional information from the same patient. Just for curiosity's sake, you can see the systolic and diastolic blood pressure are slowly increasing during this time period. I don't know more about the patient to tell you why that was, why the blood pressure was slowly increasing. We can also see the pulse was slowly decreasing, which is interesting. I don't think they had an intracranial lesion or anything going on there. And then you see activity tracking as well. For the same patient. And you can see during the admission was not walking too much. But you can also see overall, this was not an exceedingly active patient. Barely cracking 1,500 steps per day. And something motivated him towards the end here. Maybe he went on vacation and started walking around more. I don't know what happened, but you can see how having information is one step towards helping improve care, and there's a lot in here that would need to be parsed to figure out exactly what we can do to help the patient further. All right, so I want to talk just for a second about another initiative. We're going to unsheath the app here and talk about patient engagement through technology in another way. And many of you are familiar with the MyChart mobile app. Do you all use the MyChart mobile app, or you're familiar with it? All right, so you know the app that we all know and love here. You can change the color of it, but there's not terribly much that you can do to customize the app. And one thing that we felt would be helpful is customizing and branding the MyChart app, and so that our patients could more easily find it in the App Store. And so we could add content that was relevant to them. And we wanted to make some of this content available to those who weren't yet MyChart users, but they could still find a use for the app. And so Epic actually announced a little over a year ago the intent to create a library to help create a custom MyChart app. And we immediately raised our hands and said, yes, we want to work on that. So we've been working with Epic on a beta library to do this. We didn't want to go off on our own and create a completely custom app without Epic's help, because we felt that in working with Epic to do this, what was created and produced would then be available to every other Epic customer, which is a much better outcome than creating this completely standalone, non-shareable widget. And so this is actually what ended up being created. And this is a custom interface, and we intentionally kept it fairly close to the standard MyChart interface so it wouldn't be too foreign. But yet at the same time, we added some functionality. I'm gonna show that to you now. All right, so I'm gonna change gears a little bit right now and talk a little bit about history, a very short computer history lesson. So if you can think about where you were in 1983, I know there are people in this room who weren't even born in 1983. But in 1983, this was released. Does anyone know what this is? Which app this is? Application as they were known then?
Is it right?
It is not, but close. Clearly it's a Mac operating system, right? So it's actually Microsoft Word on the Macintosh. So interestingly, the first version of Microsoft Word that had a GUI, a graphical user interface, was written for the Mac. This was back when Steve Jobs and Bill Gates were best buds. They were both with their own startups in Microsoft and Apple doing really cool stuff and had a very good working relationship. And they actually always had a pretty good working relationship. But the first version, even before it reached the PC, it reached the Mac. And interestingly, you can see here a number of design elements that haven't changed a whole lot, even to the present day, right? I mean, you could pick this up and start using it with no training whatsoever. But let's move forward. 1989, so this was the first version for Windows that was created with a GUI, Windows 3.1. Rocking in the late 80s. And you can see it's basically the same thing that they had for Mac, it just had some color to it. Slightly higher resolution. I think this was maxed out at 640 by 480 resolution, which is probably about this much space on your phone these days, as high resolution as your phones are. 94, this was for Windows 95, I believe, and the biggest change here is just more screen space. So 800 by 600 resolution. Going up a little bit. And then here, 1996, and the birth of Clippy. I heard some groans out there. Your favorite user assistant. And it's interesting because we now use, without any hesitation whatsoever, things like Siri or Cortana. And of course, Clippy is part of that family tree and moving down, having some sort of assistant to help you through. So it had to start somewhere, but I think Clippy has become the computer equivalent of like Jar Jar Binks in the Star Wars universe, right? Not the most fondly thought of. And here you have the first version for this Windows XP. You can see the garish blue. If any of your systems are still running Windows XP, you should probably slowly or quickly pull the plug on those. They're no longer supported as of I think 2 years ago. But the biggest new feature here in this version of Office 2003, was actually the right-hand bar here. So this is the first version that was connected to the internet. Amazing concept, which I don't think I ever used once, but it was there. And again, it had to start somewhere. For you to get help online with how to use Word. The next version, Windows or Office 2007. This was the first version that introduced the ribbon. It completely changed the UI, which everyone got really upset about to begin with, and then finally they realized that it actually probably was a better way to do things. And then Windows 2010. They just decided to change the color because that's what they did. They wanted to make it look different. And then today, you can even use Microsoft Word full version, complete compatibility on iOS devices or even Android. You can use that. So why in the world am I talking about Microsoft Word right now? That's probably what you're wondering. So think about this progression of software. And if you could superimpose that on the timeline for EHRs right now, where are we in our relative progression of EHRs right now compared to where Microsoft Word is? You can just yell out any. There's no right answer.
81.
81. So even before.
1965.
65. So we're in the mumps era, the genesis of mumps. 2003. Okay, so we got 2003. All right, so not too bad. What's that? 89. All right. Again, there's no right answer, and in fact, you could say, 2003. Obviously, our EHRs are internet connected, right? So we've got that. We actually have mobile apps for our EHRs, so we've got that. But I think the point that you bring up in saying 81 or 65, or really old dates, are that there's a general dissatisfaction with the current state of EHRs. I think we would all agree with that, and that's good. You need to keep that dissatisfaction because that's how it's going to be improved. And I presented this in many different places. Everyone always says something on the top row. It was actually the first time anyone said 2003, I think. So it's a progressive group here.
Low standards.
Low standards. I didn't say that. Everyone knows who that is, I'm sure. But clearly there's a dissatisfaction with EHRs, and we need to recognize the limitations in order to move forward. But it also shows that there's a long ways to go, but also a lot of work that we need to do in order to improve it and to help do that. So, could it be that our platform moving forward actually is the EHR? And in this case, we have Epic, we use Epic, and then Penn uses different systems, slowly moving to Epic. But there are lots of different systems out there, and EHRs, for better or for worse, are going to be with us for a long time. They serve as the backbone for many of our clinical operations, and serve obviously a critical role in helping with now population health and analytics and outcomes-based research. And we need that structure in order to do all these great things with analytics and big data and all the cool stuff, natural language processing that we want to do. So they're not going anywhere. But the problem is we have so many of them, so many EHRs, and despite the work through meaningful use and other initiatives, they still don't talk to each other in the way that we would like. They're still not as standardized as we would like. So wouldn't it be cool if we could take all these and rather than having so many different EHRs, we could use one standard? And so I'm going to talk about, you've probably heard of SMART and FHIR, and why this is important. Now I have to mention that when I talk about SMART and FHIR, it's often, you've probably heard of the Gartner hype cycle, the Gartner hype curve, where you have any new idea, and you can Google it now. I won't judge you if you start using your phone to Google it. And you have an idea that immediately takes off. There's a lot of promise, and it reaches the peak of inflated expectations. And then shortly thereafter, you realize it's not all it was, trumped up to be, and you have this decrease in interest down to the trough of disillusionment, where you realize, it can't do anything. It's just a waste of our time. Let's forget about it. And when the reality is, it actually comes back up, and you have the plateau of productivity or something. I don't remember what it is, but you kind of get the point. Where you realize that it's not as good as you thought, it's not as bad as you thought. It's a tool, and you have to, like any tool, you got to find a good use for it. And I think FHIR right now is at the peak of inflated expectations, that it's going to solve all the world's problems, and it's probably not that good, but I think that it certainly is promising moving forward. And so for those of you who might not know what they are, FHIR it's an open source interface that's developed by HL7, and I'm sure you're all familiar with HL7, who has created multiple standards in the past. It's been endorsed by the ONC, the Office of the National Coordinator for Health IT, all the major EHR vendors, and the key is that it uses familiar standard technologies like REST-based protocols and JSON, also XML if you want to. And what SMART does is it takes those APIs and it adds on the bits that are missing, like standardizing the authentication workflows, thinking about branding and consistency there, and makes it possible to create a complete app that you can plug into an EHR. FHIR by itself doesn't give you the complete package. It needs a little bit of glue to give you that complete app, and that's what SMART adds to it. And just to show you here, this is mostly for your reference. If you go to HL7 website, you can read all about FHIR. I'm not going to go through that now. And obviously you can't read anything that's on there anyway. And then the SMART website, if you go to smarthealthit.org, you can read about that. Again, both of these are completely open source and both free to use. And that's a huge distinction. Prior versions of HL7 actually did require some licensing in order to use them, whereas SMART and FHIR are completely royalty-free and open source. And then here, you also can't read this, but on the left, it lists all the different FHIR resources. And FHIR is divided into what's called resources. A resource is basically the standard for a certain type of data. So you have a resource for patient information, like demographics. You have a resource for medications, a resource for problems, a resource for family history, etc. And then on the right there, you can go to the app gallery, which is on the Smart website, and this is the key to me and why I think that Smart and Fire won't fall completely into the trough of disillusionment, and that is because people have done real things with it already. And the fact that people have done real work to show that the validity of the technology is why it's going to temper that fall. Down at the lower right-hand corner, it says Duke Pillbox. It's one of the apps that I'll show you here in a minute. So let's jump right into real apps and what we've done. You probably recognize this. This is Epic, and this is a standard growth chart functionality. Well, imagine if you could improve this in some way, maybe to better meet your needs. And there's actually an open source smart-enabled app called Pediatric Growth Chart, which was developed at Boston Children's, which we've been able to seamlessly integrate into Epic. And you know, the interface is different. You could argue that that's better, a little more colorful. If it's more information on the screen, which in some cases is a good thing, sometimes it's information overload. But this is a completely interactive widget, and we integrated it without modifying the code as a proof of concept. And we had this in our proof of concept system as of January 2015. And we actually worked, we have a team at Duke who had built our homegrown EHR prior to moving to Epic, and we worked with them to modify our Epic 2014 to support the Fire APIs. This was before Epic had really announced that they were definitely going in that direction. We had started this process pretty early, and Epic has since announced that they're planning on supporting it. And Gordon mentioned, you know, that you have 2015 in your POC environment, I guess, and just kind of in testing, and that does come with some Fire APIs that you can start playing with. But the cool thing about this, there are two main issues that arise with integration. One is the technical integration. You want to get the data to the right place. You want to make sure the data is accurate, but also you want to make sure that widget is in a meaningful place in your workflow. Because if this app required you to log into a separate website somewhere else, you'd never use it. You would never overcome the activation energy to log in somewhere else and to get that information. But because you can click a button here in the same exact place as the growth charts button, you're going to use it just as you would use your normal growth chart widget. And that's the key here. And a lot of the work that we spent was figuring out how to get this into the Epic workflow in a meaningful way, in addition to making use of the standards for the data. But because we can get this in here in a meaningful way, this is actually a website. So the Growth Charts app is a web app. And we can actually put that in more than one place. So this is hyperspace, but we were also able to show that this works in Canto, the mobile app. And we showed this at UGM as well. Of course, the app itself is not mobile optimized, and so it's still a desktop website sort of crammed into mobile, which becomes pretty hilarious when you have it on an iPhone, which is possible. We did it, but obviously the app would need to be modified if it were to be usable. But that's all work that can be done. I mean, that's just dressing to fix that. The proof of concept is, it took, after doing all the work to get this growth chart app working in hyperspace, it took about 5 minutes to get it working in Haiku and Canto. It's literally one record that you needed to change and add, and you're done. That's how easy it is, and that's why this is so exciting for us. And then we did one more thing. We actually, there's an iOS version of the Growth Charts app that was also created at Boston Children's, and we demonstrated how you could have a native iOS app and log directly into your EHR and pull data from it using a native app as opposed to a web app, just to show how flexible this is. So now I'm going to show you a demo of this. This is something we created for HIMSS, and it's going to kind of go quickly through it. We had a slimmed down environment for HIMSS, so we wouldn't show all of Epic. But here you can see the pediatric growth charts that I just talked about. The fact that it's interactive, it's being pulled up right in the patient context. You'll see information in additional ways. And you can also see a tabular format. I don't know why you ever want to do that, but you can. And then this is most interesting. This is something that's a parental view that we hope to make available within MyChart so patients can see their child underweight, normal, overweight, or obese. The second app is called Medication, and this one uses the FHIR resources for patients as well as medications. And this is intended to be a patient educational tool to give patients more information in a simplified way that they can take home with them. The key to this app, though, is that app is actually available in 16 different languages. So you can print out the medication list in like 16 languages, and it's all built in, which is one reason we thought that was cool. And then the last one, this is the Duke Pillbox, which is an interactive exercise. And here, we actually worked with a company called MedAppTech and built this web app. And this is actually an iPad now. This is an iPad they're on. They scan this QR code that brings in all these medications into the iPad app. And the QR code was generated by a smart-enabled app that lived in the EHR. And then the patient can then drag and drop these medications to try to teach themselves what their medication regimen is on a daily basis. And then they can check to see if they're right or not. They can get a hint to see what they did wrong, and they can go ahead and correct that until all the boxes are green. And then they know that they did it right. And then this information is then saved back and can be viewed within hyperspace as well. And then finally, showing you the same thing on mobile, how easy it is to add this to Haiku and Canto. Again, not a mobile optimized website, but that's something that could easily be changed. We didn't bother changing any of the app itself as part of this. That's pediatric growth charts. And then finally, charts for iOS. So that button was tapped. It took you from Haiku with the patient context into a native iOS app, logging in with a fingerprint here, with the same Duke credentials and pulling data directly from the EHR. So you can see how you can have some integration between mobile apps and then native apps as well, which is pretty neat. So that's smart and fire. The other thing that I would mention is the reason we decided to use a QR code for the growth charts app was because we did not want to have a tablet that was logged into our EHR and then hand that to a patient. We didn't feel like that was the best thing from a security perspective to do. And so the nurse or whomever is accessing the pillbox from hyperspace pulls up the QR code, it pulls data directly from Epic. All of the medication data is actually built into that QR code. We found out that a QR code can actually hold up to 2 kilobytes of information. It's a lot. You have most QR codes are tiny and hold a URL. You can actually put a lot of information. And so what that did was we can scan that with the iPad, and then there's no connection to the EHR. You're pulling that data over, and then you just hand that to the tablet, and so it's much more secure. And so that's why we decided to use the QR code. All these things you got to think about from a security perspective. So where does Smart and Fire go after this? Well, one of the other projects that we had worked on was with Jeff Ginsburg in our Center for Precision Medicine, who had developed an app and a framework called Mitri, which is a family history app that was designed to streamline collection of detailed family history information from patients, and they could use that family history information to put together and apply algorithms to it to determine a patient's risk for various conditions. And it's incredible what you can find out simply from the family history. And of course, as physicians, we actually do a really, really bad job at getting really good family histories because we don't have time. It's very difficult, and it's usually not the priority. If someone comes in with a with a broken bone or with a simple infection, we usually don't get all that information. But there's a lot there that we can do. And so this app was intended to do that. And we were asked by the White House to present this at a Champions of Change for Precision Medicine event this summer, and we've committed to making this app available within MyChart using Smart and Fire, so that eventually we can collect higher quality data from patients to contribute to the precision medicine initiatives out there. And here you can just see, I'm not going to read this to you, but why family history is an effective genomic test and the different aspects it can help with us. And I believe there are 16 different algorithms that have been developed within this application that can be applied to a multi-generation family tree to give you your risk for various conditions. And then this is what the website, or what the website looks like in a little more detail. All right, so one of the last things I'm going to talk about is Epic and mobile, and this is something that I presented at UGM previously, but integrating some of these things with the EHR. And when I arrived at Duke, there are, I think with every EHR, you're concerned about how interoperable and how customizable it is. And we found that Epic was actually far more customizable than at least I thought to begin with, especially with respect to mobile. And the way the mobile apps are created, most of the content you see within the mobile apps actually loads a website, or it's actually web content. And that web content is within a structure called a print group. I have no idea why they call it a print group. Probably had something to do with printers a long time ago. But a print group is basically a widget now that can contain any type of information. But I think Epic needs to rename that to clinical widget or something, a CW. But they haven't yet, and they're not probably going to take my feedback on that. But one thing that we wanted to do was try to make that more useful. And one of the tools that I'm sure you use here with some regularity was BillyTool. And BillyTool was something developed, I believe Stanford originally, and put out there as a free tool. And it's fantastic as a clinical decision support tool, but obviously the downside is that it requires you to manually enter data into a website. And anytime a human being is manually entering data, there's an opportunity for error. And we want to try to eliminate that error. And so there's actually a work that had been done by Peter Greco at Metro Health to integrate BillyTool into Epic. And you may be using that functionality now. Is this integrated into Epic now or not? Okay, so something you could possibly do. And so we had seen a presentation that he did several years ago on integrating BillyTool directly into Epic, and we said, that's cool. Can we do that on mobile? And so I actually reached out to him. He sent me all the code that they had done to integrate it into a print group within Hyperspace. And then me and our team set to work seeing, well, could we add this to a print group within mobile? Because that's where we're using it. And so we worked to do that. But I wanted to show you here, how do you take this information and make it easier to use? Well, one solution, and people come to me all the time saying, I have a great idea, I want to build an app. And many times an app is actually not what they want to do. They think they want to. But if you see this, and so I actually, just sort of as a proof of concept, created an iOS app and an Android app that allowed you to access this information and enter the age and the bilirubin and view the risk assessment. And it worked. It basically showed you the website once you clicked OK to view risk assessment, but it still had the problem of manual entry. So then I modified this slightly so that you could create a URL that could be loaded into the app, and it would manually populate that. And you could create that URL using Epic or something else, and we had our proof of concept there. But ultimately, the best use is to have something that's completely integrated that does not require a separate app. So we determined that that's not the best idea, to create a manual app for every single clinical decision support widget that you need. It's inconvenient, it's costly, and you have to learn multiple interfaces. It just doesn't make a lot of sense. So instead, we actually decided to add a button right to the print group in an analogous position as to what Peter Greco did within Hyperspace. And we figured out how to make that work. And then when you tap on that button, it will then load, it will pull the right data elements directly from Epic. In this case, now the date of birth, the current date, so you calculate the hours of life, and then the bilirubin value. And it will calculate that URL, and it will load it directly within Canto using sort of a web view. And this functionality we felt made much more sense. You're right there within Canto or Hyperspace, one tap, and you have what you need. No risk of transposing that data incorrectly. And so we took that and said, well, is there anything else that we could do here? Now that we've figured out how to create a button within Haiku Canto, what else can we do? And one of the things that I thought would be very useful is integrating UpToDate into the apps. I use UpToDate all the time, as I'm sure you do, to access clinical content. And you often want to look up a specific problem about a patient. And so we thought it might be useful to include an UpToDate button within the patient problem list, as well as the patient medication list, because I often use UpToDate to look up the medication information. And so we did that. And then when you tap on it, it pulls up to date right here, right within Haiku again, to give you access to that information without having to search for it. And then our medical library actually saw some of this work, and they got really excited and said, well, we've been trying to put together a website that collates all these useful resources and allows you to search for one term, and it shows you the results from multiple sources. And they said this would be a great place for that. And so we worked with them. They created a mobile interface, which then allows us to, again, from this one button, perform a query, and then you can tap any of those buttons and it will show you the information from that specific resource. And again, we think this is a great way to get the information right there at your fingertips. And you can see here, for example, PubMed for heart failure, in addition to UpToDate. All right, so the last thing I was going to talk about is ResearchKit. And if you're not familiar with ResearchKit, this is an open source framework released by Apple it was announced in March and then actually released in late April of 2015. And to me, the exciting thing about ResearchKit is that it standardizes the workflow for patient consent. And this is electronic self-consent. But it also includes some widgets that standardize the ability to collect information via surveys, and also includes things such as active tasks, which use the hardware within the phone itself to collect information, such as motor activities, fitness using activity trackers, and cognition voice. Actually has a Parkinson's widget that can detect shaking and a swaying of your gait as you're walking. Pretty neat stuff. At Duke, we got very excited about this, and I think across the country, people got very excited because of the potential to scale your clinical question or your study from a potentially small cohort to lots and lots of people. And so we started on this very quickly, and there was a team that I had met that's doing autism research, and we immediately we teamed up with them, and then they had a team that was ready to go to start building this, and we created an app called Autism and Beyond. And we started this work in March, April, almost soon after the announcement, and the app was released in October. And it was, I can't go into it all right now, but it was a massive amount of work, far more than we even expected. We initially thought that, knowing that this is Apple, that the framework that they released would be very easy to use and kind of drag and drop, and boom, we'd have an app in no time at all. The reality was far from that. It was something that we had to do a lot of manual coding. We could use the ResearchKit aspects, but the entire app around it, we needed to build from scratch. We also needed to build the back end to support it from scratch in order to make it happen. It wasn't something Apple provided. But the app itself, as you can see here, the intent of the app is to show video stimuli to children, whether they have autism or not, and then record their facial features as they're watching these videos. And prior work done by the study team has shown that children with autism react differently to these videos than a neurotypical child. And this is obviously something that we want to get into as many hands as possible to validate the technology, in the hope that one day we might be able to use this as a screening tool for autism, especially in places around the world where they don't have enough providers, which frankly is everywhere in the country. We don't have enough childhood mental health providers to do the screening and diagnosis that we need. But just to put this into perspective, one of our collaborators is in sub-Saharan Africa. He's actually in Cape Town, South Africa, and he runs the Autism Center for all of sub-Saharan Africa. And he told us that there are about 900 million people in sub-Saharan Africa. About half of them, 400 million or so, are children. And for those 400 million children, there are 50 childhood mental health, child psychiatrists that can do this type of diagnostic workup, which is very complicated. As you know, it takes multiple hours to do a formal diagnosis. You can do screening quickly with MChat, which is not a very specific test, but to do diagnosis is much more burdensome. And so being able to screen children more appropriately in advance will help those limited resources only see the kids that they need to see, rather than a bunch of kids that may not need that. So here you can see what the app looks like. You can download it now. It's available in the App Store, and you have to have a child between the ages of 1 and 6 to participate. But we did make the technology itself available before you consent. So you can actually download the app, and it will analyze your face and show your facial expressions. We're not recording anything with that, but you can at least see how the technology works. And here you can see we added a graph to show the number of participants so that users can see where they fall with respect to some of these metrics, age of the child, for example. And this was released in October 2015, and one of the quotes that I really liked was from Charlie Worsel of BuzzFeed. He said, "Earlier this week, I stared into the front-facing camera of an iPhone and contorted my face into a deep frown, and with the twinkle of a few green dots, caught a glimpse of the future of handheld healthcare." Now, I think that probably sounds a little bit grandiloquent and over the top, but I think that the reality is a lot of that the future of healthcare is increasingly to do with technology and to use technologies in novel ways to really help patients. I think we can have all the cool technologies in the world, but it's what we do with those technologies that makes a difference. The technology in and of itself is not the end. It's not our goal. It's to apply that in meaningful ways. And so to end, I just want to show you a video that came from that we had created for inclusion within our app, and these are all parents that are talking about the need for the autism research.
They all have different personalities.
My first one never threw a temper tantrum ever. My third one does not throw a temper tantrum ever. My second one is king of temper tantrums.
She'll go boneless in a second, just, collapse on the floor.
When she was 18 months, she would say like, "Got this," and "Mama, Dada," and then all of a sudden she just stopped.
You leave the hospital and they don't give you any instructions.
With our first child, we were constantly asking, is this normal?
When they don't meet milestones, my immediate reaction is, oh my gosh, what's wrong?
I know it's going to be okay, but I don't know, I just keep worrying. Everybody worries, but when is it something that is bigger than yourself?
When she was about 6 or 7 years old, we got a diagnosis of autism. And autism can be diagnosed far younger than that. And if my daughter had been diagnosed several years earlier, it would have helped us and calmed our anxiety down to be able to take better care of her.
You just want the best, and we know that research is important.
No one wants to see their child suffer.
I don't want someone else's child to go through something that maybe studying my child a little bit could have helped.
And that's all you can really hope to do, is to make a change today that's going to ripple into another generation.
But worrying, gosh, that's part of the deal. That's part of the package.
I think the main is the love between the parent and the child. This is a really amazing thing for your life.
So I think that all of us are impacted in some way, whether directly or indirectly, by individuals who have chronic health conditions. And I think we all have motivations to help find solutions to those problems. And hopefully some of the technologies that I've shared with you today will maybe pique your interest or give you some ideas on how you can apply those technologies in novel ways, and work with the excellent faculty that you have here to put some of these into practice and to find solutions to all the problems that we're currently facing, so that we can move and improve healthcare moving forward. And so with that, I thank you for your time, and I'm happy to take any questions you might have. Thanks.